We have discussed empiric treatment of pneumonia as well as de-escalating from empiric therapy to pathogen-directed therapy based on microbiological results. Now, let's evaluate a patient's clinical stability to determine if antibiotic therapy can be switched from IV to PO. Now, IDSA guidelines for community-acquired pneumonia gives us some guidance for switching patients from IV to PO. Now, keep in mind that community-acquired pneumonia can be treated as outpatient in, moderate or less severe patients, whereas in hospital patients, the patient will receive IV antibiotics. So, based on IDSA, patients who are hemodynamically stable and clinically improving can be, can be switched from IV to PO as long as they are able to tolerate oral therapy. Another thing to consider is to make sure that the GI tract is also functional. And we can apply some of these principles to patients with nosocomial pneumonia. Now, the reason we want to switch patients from IV to PO as soon as possible, when they can tolerate it, is, first of all, to make sure that we don't introduce any, line infections, as well as getting patients ready to be discharged. However, keep in mind that the guidelines do say that inpatient observation while receiving oral therapy is not necessary. So if the patient is ready to be discharged from the hospital and they're on IV antibiotics, and it's okay to discharge them and send them home with oral antibiotics. It's not necessarily to keep them one extra day to make sure that they tolerate the oral antibiotics. Now, there was a systematic review published in JAMA in 2016 that looked at the evidence for, criteria helping transition patients from IV to PO. So basically, absence of mental confusion, ability to take oral medications, absence of fever, hemodynamic stability, which is defined as heart rate less than 100, and systolic blood pressure greater than 90. This is without using pressors. So, without using norepinephrine, the blood pressure should be greater than 90. Another criteria is respiratory rate lower than 25 and oxygen saturation higher than 90%. And of course, we have to make sure that the patient is clinically improving before we change from IV to PO. And sometimes the patient may not be improving, and there could be different reasons for it. One reason, of course, could be that, we have identified the correct organism, or empirically we are targeting the right organism, but we use the inappropriate antibiotic, or we were using the wrong dose. So it's important to, target the right organisms, use the right antibiotics, and also use the right dose. So, we have to make sure that the dosing is appropriate based on body weight, based on renal function, based on hepatic function, and based on drug disease, and drug-food interaction. So, as pharmacists, we have to take all of those considerations to make sure that the patient is receiving the right dose. And along with the dose also goes the right frequency. The frequency is also important. Sometimes, the organisms can develop resistance while on treatment. So it's, another thing to consider if the patient is on the right drug and on the right dose. You may want to question, whether the organism developed resistance while the patient was on the antibiotics. So sometimes we may send another culture just to make sure that the organism is still susceptible to the antibiotics we're using. I talked about the wrong dose. Sometimes the patient may miss a dose. So let's say the nurse comes to administer the antibiotic and the patient is not available. So whether the patient was sent for imaging or the patient, was not available for any reason, that's important to consider to talk to our nurse colleagues to make sure that the antibiotics were actually administered. Another thing is to make sure that the antibiotics are actually getting to the site of infection. So sometimes, if the organism is in a specific area where antibiotics cannot get, source control becomes really important. So empyema, for example, is an example. Is when we actually need to make sure we have source control because antibiotics may not be able to get there. So it's important to actually drain the site of infection. In the case of pneumonia, sometimes the patient may still have like shortness of breath and not seem like they're getting better, and could be due to other reasons that has nothing to do with pneumonia. And of course, we have to target the right organism and use the right empiric therapy to target those organisms. And also we should think of non-infectious causes. If the patient has fever due to either a clot or cancer, non-infectious causes of fever. Sometimes we may have drug-induced fever. So beta-lactams, for example, occasionally cause drug fever. And lastly, presence of an unrecognized concurrent infection. So if you're trying to target pneumonia and suddenly the patient has bacteremia that led to endocarditis, that could be something that's could be the reason why the patient is not doing well, and that's important to consider.